I'm Armin Ghobadi. I'm a physician and oncologist at Washington University in St. Louis. I mainly practice cell therapy. My focus is cell therapy and bone marrow transplant for hematologic malignancies. We have a center here at WashU. We call it Center for Gene and Cellular Immunotherapy, or CGCI, and I'm a clinical director of this center. All clinical trial, standard of care, and homegrown cell therapy products go through this program, including CAR-T, TCR, T-viral, CTL, NK cells, TLs, and viral CTLs, as I mentioned, like Tabelecleucel. So EBV positive post-transplant lymphoproliferative disorders, or PTLD, that's from now on, I'm going to call it EBV positive PTLD. It's a rare type of lymphoma that is driven by a common viral infection called EBV. Mainly is seen in patients with history of allogeneic stem cell transplantation or solid organ transplantation that they are on immunosuppressant to prevent graft versus host disease or graft rejection. So EBV is a common infection and depends on what population you look at. A majority of people have this infections and is asymptomatic, not causing a trouble because it's dormant. But in patients after transplant, because they are on immunosuppressant medication that suppress immune system to prevent graft rejection or graft versus host disease, that can give basically a space to the virus to proliferate and get activated, and that activation in some of the cells can convert a normal cell to a malignant cells. And in the EBV positive PTLD, that activation of that virus in mainly patients' B cell is causing that specific lymphoma for a patient. Could affect other cells, but mainly it's B cells. The standard practice is stopping. That is difficult to stop, but decreasing the dose of immunosuppressant medications is the first step. Using anti-CD20 monoclonal antibody like rituximab, or in the case of more aggressive, basically PTLDs, using rituximab plus chemotherapy. Unfortunately, the chance of response to upfront treatment is not universal. 30 to 50% of patients do not respond to the first-line treatment. And among those patients that they respond to treatment, roughly half of them relapse, and majority of those relapses happen within a year after achieving the first response. Tabelecleucel, or Tabelecleucel, is an allogeneic, off-the-shelf, non-genetically modified immunotherapy specific to EBV positive cells and can bind and eradicate EBV positive cells, including EBV positive malignant cells, and is working through natural ways. So the way that our normal T cells bind to infected cells and get rid of them as a part of normal immune functions, there's a receptor on the surface of T cells called T cell receptor, and the T cell receptor bind to infected cells by a receptor on the surface of infected cells that is called MHC class 1 or a restricted HLA. And that specific MHC class 1 on the surface of infected cells present the EBV-specific antigen or antigen of interest to the T cell through that basically synapses or binding of T cell receptor with MHC class 1 and antigen. So that's a normal way that our T cell in general bind to infected or malignant cells when they work to get rid of malignant cells. But because of various reasons, normal T cells cannot get rid of infected cells or malignant cells. Tab cells, or Tabelecleucel, working through that specific natural pathway, and because of that, should match that restricted HLA on the surface of malignant cells. For people that are familiar with the CAR-T, so CAR-T is a T cell that has a chimeric antigen receptor on the surface. For that type of treatment, you do not need a restricted HLA to match your TCR or T cell receptor in your product. For a Tabelecleucel, that's a viral CTL, still because it's acting through natural pathway of T-cell receptor and restricted HLA, the Tab-cel should match restricted HLA on the surface of malignant cells. So when that matching happens, which is the EBV malignant cells, or EBV PTLD cells, and you have a Tab-cel, when it's matching that restricted HLA, binds to the malignant cells. And when that attachment happens, Tab-cell release granzyme and other factors that basically kill the malignant cells. And that's the way that is working. So how you make Tab-cells. So Tab-cell, as I mentioned, is an allogeneic immunotherapy. So EBV positive donor, T-cells from healthy EBV positive donor are collected and used to manufacture Tab-cell lines. And as I mentioned, because it should be matched to the tumor HLA or restricted HLA, so diverse group of EBV positive normal donors, T-cells, are used to manufacture a large or diverse, basically, lines of Tab-cells with the goal of covering 90% of population. So when the patient has basically EBV positive PTLD, how we choose the cell for that patient, basically, we look at the HLA typing of a patient, HLA typing of a donor, in the case of both allogeneic stem cell transplantation and solid organ transplant. And based on those, we find and send that to manufacturer, basically. Based on those HLA typing, we find a Tab-cell line that matches restricted HLA of the patient and is given as an IV, quick IV administration with 1 hour post-administration, basically monitoring. We do not need inpatient hospitalization, can be given completely in outpatient setting, and is given in cycles, 35-day cycles, and in each cycle, patients get 3 of them on day 1, 8, and 15. They get three infusions of Tab-cells in 35-day cycles. In terms of the cycles, to just follow up of that, how many cycles patients they get before talking about the results, safety, and efficacy. So patients get basically with the EBV positive PTLD that they have been exposed to rituximab or rituximab plus chemotherapy. They were refractory relapsed, were enrolled in this study. They could be on some immunosuppressant, but the lowest possible per treating physician before going on the study. If you are on prednisone, they could be on prednisone as low as 0.5 milligram per kilogram. 26 patients with PTLD after allogeneic stem cell transplantation, EBV positive PTLD after allotransplant, and 49 patients after solid organ transplant basically were enrolled, and we're reporting the updated result of those patients. As I mentioned, patients were getting cycles of EBV CTL or Tab-cells, 35-day cycles on day 1, 8, and 15. And on day 28, we're looking at the response. And based on that response, we're deciding continuing the same cell line or changing to a different Tab-cell for the subsequent cycle. Patients were getting cycles up to maximum response or unacceptable toxicity, or in case of no response, up to 4 Tab-cell line in post-allogeneic stem cell transplantation and a 2 Tab-cell line in post-solid organ transplantations. Median age, the patients that enrolled in the study ranging from 2 to 82 years old. Majority of patients had high-risk EBV positive PTLD. Close to 70% of cases were diffuse large B-cell lymphoma in terms of a subtype. And median lines of prior therapy was 1, ranging from 1 to 5. So it's a group of refractory EBV positive PTLD patients enrolled. In terms of safety, was very safe. No death related to Tab-cell was reported. Adverse event of a special interest for cell therapy, I'm going to go over those, like cytokine release syndrome, no CRS was reported. In terms of neurotoxicity or immunoeffector cell-associated neurotoxicity, no ICANS was reported. No tumor flare was reported. Graft versus host disease, because these are donor cells that match just at 1 or 2 HLA. That's the risk that we look. Just 2 out of 26 patients post-allogeneic stem cell transplantation and none post-solid organ transplant actually developed transient graft versus host disease. Basically, 2 out of 75 patients. and they were transient, treated and resolved. In terms of allograft in a post-solid organ transplant, rejection happened in 3 out of 49, all treated, 2 of them completely resolved. So very basically appealing safety profile. In terms of efficacy, the response was overall response for the whole cohort was 50%. That 30%, close to 30% complete response and close to 20% partial response. But more important, the response was durable here. Median progression-free survival was close to 24 months, and 1 year, an estimated 1 year progression-free survival was close to 75%. That is very good for this group of patients. Just as a reminder, patient with relapsed refractory EBV positive PTLD as a standard of care, they have a median survival of 1 to 4 months. So this is way more than what you see in a standard basically setting. In terms of overall survival, 12 months estimated overall survival was close to 80%. So that's very good in responder patients. One other important factor here is regarding switching of a Tabelecleucel, because as I mentioned, you can use different cell line. A majority of patients enrolled in this study just got one Tabelecleucel line. And around 8% of a patient switching one Tabelecleucel line to another one resulted in conversion of no response to a better response. Basically, in that 50% overall response, 8% of that happened after switching one Tabelecleucel line to another one. The PDUFA date is January 15, 2025. BLA is under priority review right now. And Tabelecleucel is actually already approved in Europe. Was approved in December of 2022 for EBV positive PTLD patients ages 2 and older after failing rituximab plus chemotherapy. With this data and a safety profile and efficacy and really no significant comparable standard of care available for this group of patients, we are hopeful that we're going to have access to this for our patients.